Welcome to the OShow. I'm Laura Babcock. In the last few months, we've been looking at the crisis in healthcare in Ontario, and we've done a number of shows on vulnerable populations, including people who are experiencing homelessness. And so I'm very pleased today, as we see the cold weather taking grip on our province, to have two people who can speak to exactly what is happening in community health and what more needs to be done. So joining me here on the program, we have Sarah Hobbs. She is the CEO of the Alliance for Healthier Communities, an organization that really is an umbrella with 100 member organizations or so within it. Tara Gross-Taylor, she is the CEO of Community Health Caring in Kitchener-Waterloo, and one of the largest refugee health centers in Canada. First of all, what is community health and well-being, and what is the situation happening in our communities? You know, what is the level of need, of risk even?
Thank you very much for the question. Community Health and Wellbeing Week is an annual event that the Alliance for Healthier Communities and our members participate in, and it is to raise awareness for the need for the supports for communities across Ontario, whether they be in an urban setting, a rural or remote setting, about the need for community health organizations like Tara's organization, which definitely are important because they marry primary health care with community outreach, community support, social determinants of health, all of the various programming and services that are required that have a health equity lens that ensure that people that traditionally face barriers to mainstream healthcare and accessing physicians, accessing nurse practitioners and other supports are able to do so in a way that is geared to their needs. And it's very much driven by the community that they serve. So all of our member centers are community governed, meaning that the community directs the organization.
So it is the communities then that really determine who the vulnerable populations are. And so I noticed one of the things when I was looking up your organization, Sarah, is that something like people who are vulnerable populations have like 70% more need for medical health and wellness interventions. I mean, what does that look like? And who are we talking about when we talk about vulnerable populations?
So we're talking about an ever-growing and increasing population of folks that are at risk for various poor health outcomes compared to what we would call the average person and living in Ontario. And so our members serve, I think you're probably referring to, our members serve people that are 68% more complex, which means that they have medical complexity, but also they likely have complexity within their social determinants of health, whether that be housing, employment, other kinds of issues that would impact racism and other things that would impact their ability to achieve what we would call the best possible health outcomes in Ontario. And that need is increasing for all kinds of reasons, including post-pandemic realities, the inflation, housing market crisis, all of those things. The increase in mental health and addictions needs in Ontario is on the rise. And so our member centers are the ones that are there providing those comprehensive set of resources and supports that really allow folks that are equity deserving or vulnerable to be able to access those without barriers.
And I want to get to a little bit more about some of the benefits of the kind of approach that you take, because one of the things that certainly you champion as evidence of the work that you're doing in the communities is that there are less visits to the emergency room. And we're seeing just this week in Ontario, emergency rooms are closing in some communities because they can't take any more patients. I mean, it really is a critical situation. So I want to get to that in a moment. But in talking about vulnerable populations, Tara, one of the groups that I think are included within that are often newcomers and refugees. In particular, because they arrive with complex needs. What kind of need are we talking about, and is it increasing? And how do you approach those populations that have so many of the things going on that Sarah just itemized?
Thanks so much for the question, and thanks for having us today, Laura. Yeah, absolutely, and I'm sure we've seen it. We've seen it all over the news recently. We have so many new Canadians who are seeking refuge in our country, and with Kitchener-Waterloo being a key settlement area in the province, we're seeing exponential growth, and we're anticipating an additional 227% growth rate over the next 4 years. of newcomers and refugees in our area. So we have been collaborating very closely with our partner agencies who work in settlement, as well as other agencies who are providing sort of that first line of primary care, health and wellness, counseling. And I think when Sarah talks about sort of the acuity and complexity level of folks that we're seeing, in particular with refugees, you're talking about individuals who have fled situations that create a great deal of trauma, and typically not by choice, not looking to immigrate per se. But when you have individuals who are coming under those circumstances, you're not only dealing with their primary care needs, of which there is often many, but you're also dealing with all of those mental health issues, the settlement issues, English as a second language, trying to adjust to a new community. Finding your place in a community. And I think that's when certainly we at Community Healthcare in Kitchener-Waterloo take that very seriously. It's not just about the primary care. It's not just about the counseling. It's about the whole family. It's about the whole individual and making sure that they find their place in a very welcoming way in our community. Which is increasingly challenging when there's no primary care attachment in our community. And when we have been unable to do any intakes over the past 3 to 4 years because of a lack of funding and resources. So despite the fact we're serving thousands more than we're funded to serve, we still sit with a waiting list of close to 3,000 people. So in fact, our refugee clinic saw over 35,000 visits last year. And it grows all the time. We have surprise new refugees to the community all the time without warning and without the ability to provide primary care. So we do what we can to respond urgently to those individuals.
And we're not talking about Toronto here, people. We're talking about Kitchener-Waterloo, right, with those numbers. It's mind-blowing. And there was a situation that happened right after the May 24 weekend, or about that time, where, in fact, a number of refugees were arriving. And so yourself and other organizations did a triage to try to find ways to address their care. But of course, that's not sustainable. I don't think any of us sitting here think that that's, the way things have to be going forward, or should be. But let me just address that issue of primary care attachment, because for people who are not in the field of health and wellness or community health, what does that really mean, Tara?
Basically, it means that there's no physicians or nurse practitioners available at this time in our communities. And I shouldn't say none, but there's very, very limited numbers. And when you're talking about populations like ours, whether it be our refugee population or our homeless and precariously housed population, you're not talking about individuals who typical practitioners will pick up on their caseload for a number of reasons. The way that a community health center is funded allows for us to spend the time that's necessary to serve those with those unique needs and with those barriers to access because of the way that our staff are funded and because of the setup. So we don't bill through OHIP the way that your physician at home may bill, and so that allows for the time that's necessary, but as such it's very difficult to find care for these folks, and so we have to build strong relationships with our community partners and our family health teams, our family health organizations, to create a pathway where we can have a warm handoff for folks who come in with that level of complexity and acuity. And ideally, we will stabilize them over time and link them to their communities to a point where they can then attach to a more traditional practitioner in the community and free up space. That's sort of what the model was supposed to be. On the ground, that's not what's happening because there isn't anyone to warmly hand them off to. And so therein lies the challenge.
Okay, and I'm thinking as you're speaking just about refugees we heard about who were living on the street in Toronto in the pouring rain, you talk about this meeting them and this warm handoff to a primary care physician, but there just aren't those now. I mean, it sounds, Sarah, like almost a insurmountable problem or challenge. I mean, what is it that the Alliance is trying to help people understand right now about the need in Ontario? Because if the numbers are going up, 200+% in terms of just newcomers coming to KW, I can't imagine how that is reflected across the province. Maybe you have some stats on that, but it sounds as though the need is going to increase severely in the next couple of years. And so what is it that the Alliance is hoping for from government?
Yeah, I think that you're right. The needs already exceed the capacity in the province, as well as an unequal distribution of resources across the province if we're thinking about rural, remote, and northern areas. And so there's a bunch of things that I think that we're trying to advocate for. One is to position primary care as the foundation of the health center, of the health system, and positioning primary care as the health system center is as the foundation is, I think, being done and being seen across the world. So we've seen precedent for this. And when that happens, that means that primary care gets the resources and the tools and the creative solutions and the investments that are going to ensure that people do have access. And we believe in attachment. Absolutely, attachment is important, but it's not just about attachment. It is about all the other things that Tara and I have been speaking about, that interprofessional primary healthcare team. And that team needs to look different in each community depending on the community's needs. And so we're advocating for an expansion of interprofessional primary healthcare teams. We're advocating for fair and competitive wages to keep folks in those teams, because right now there is a discrepancy between the acute system, the community health system, and we're losing good people to other parts of the health system. And we're advocating for base funding for existing teams so that organizations can do what they need to do and continue to expand. So if they can, if Tara were to get 3 new physician funding, and we're working with academia to try and make sure that there's placement opportunities so that people understand community health, then we can build that the resources and the capacity within some of our existing centers, and also with the implementation of new centers where there is a desert, if you will, of community health resources.
So what was the catalyst for starting the Alliance, Sarah?
The Alliance started over 40 years ago, and it was a few, I think it was 6 community health centers that came together to form an organization to be the voice for community health. And I think that the community health, the Alliance is a bit unique with that marrying of health prevention, health promotion, community health with primary care. And I think the people that came together, I mean, I can't imagine what that was 40 years ago, but I think it was to make sure that there was a voice at that provincial level to be able to advocate for those resources. And right now we play a dual role as an association. We absolutely advocate for the resources and the funding that our members need to do their work, but we also have been tasked by our members to advocate for health equity and advocate for healthy public policy and advocate for the things, if we're doing those things right, and if we're building a system with the people that face the most barriers to access, everybody's going to be able to access a system that works for them. So that's the things that we're trying to impact and influence government decisions when they're making decisions about health, that we are ensuring that lens, that equity lens, is applied.
I think that's a huge statement that you've just made there, because we have had all kinds of different shows on the OShow over the years dealing with issues around equity and barriers to access. And even during COVID, how some communities were disproportionately getting sick with COVID. And you know, it's a huge issue on so many levels, as you know. But that comment that you just made, I think bears repeating and exploring a little bit, if you'll indulge me here. When you said that when barriers are removed for people who have the most barriers, everybody gets better access to health and wellness. And I think that's critically important, because some people think it's an either or. No. You know, as I sit here listening to you talking about more funding for the community health model, I don't take it that you want it taken away from other health models. It's about more, so that there's more access, more health, better outcomes for Ontario. So can you just pick up on that a little bit? Because sometimes people think that these conversations are preferential treatment for one group or another. What you're really talking about is equal treatment in making sure that everyone has access.
Yeah, I think if we build a system that means that we may have to approach healthcare accessibility and what that means for different people, it can't look the same for everyone. And if we hear from people, and all of our centers embrace a community-centeredness and a co-design model with the people that they're serving. So they're co-creating the services. And if we can build that in a way that meets those needs. And we're flexible. Instead of it being a provider-driven system, but being a patient-driven system, then we end up with the healthcare that looks very different maybe than what it was built to look like, or the way that the policies and the things that are in place to manage and govern it look like. And we saw that throughout the pandemic. Many of our member centers pivoted in huge ways to come together and meet the needs of the community where they were at. And so if we do that, then everybody has access to the health system in that way that is tailor specific. So it's I think that it isn't an either or. And an analogy that somebody once mentioned to me, and is the door opening for automatic doors for folks that have mobility disabilities or challenges getting in. That helps people get in and out of buildings in a way, but it also helps a young mom with a stroller and groceries, or it helps an elderly person who maybe is carrying groceries that they don't have the capacity to open. So it helps a lot of different people. So if we center our planning, and if we center our the policies that govern healthcare in Ontario around those that face the most barriers, then everybody wins.
I love that. And I think that's an incredibly important message for a myriad of reasons without getting too far into politics, right? People need to understand that's what this is all about. And that's the benefit to everyone, right? The features and the benefits of community health are that it improves removing barriers for everyone when it's done through an equity lens. So I love that. I saw you nodding your head emphatically, Tara, when she was discussing about how community health centers had to pivot during the pandemic. What have been some of the lessons from that? And how does that apply going forward as you celebrate Community Health and Wellbeing Week in Ontario?
I mean, I think interestingly enough, and Sarah alluded to this, during COVID, there were various different responses across the healthcare system as we all sort of learned and evolved together to respond to the crisis. But I can tell you certainly for our organization, and I know for many of our organizations in the Alliance, the doors never closed. And the doors never closed because they couldn't. So while some providers were able to pivot, and I know we all love that word, but pivot to virtual care and other sort of mediums for reaching their patients, for folks like ours, specifically in Kitchener-Waterloo, and I know for other Alliance organizations as well, that's not necessarily something available to them. And so we had to respond. And our staff, and Sarah talked about the fact that our staff are often the lowest paid healthcare providers in the system, and they were all there every day, putting themselves at risk, putting their families potentially at risk, especially in the early days when things were very unknown. And that's the level of passion and commitment that resides in community health organizations. And I think that people don't necessarily know or understand that. And when I look at the Ontario Health pillars, the areas that they wish to focus on, it's interesting to me that they completely align with a community health center model, right? This is not something new. The right service at the right time, community-based care, faster access. And then when we look at some of the goals of ED diversion and those sort of things, we've been doing ED diversion our entire lifespan at a community
emergency department. Is that correct?
Yeah, I'm sorry, acronym heavy. The emergency department. That's what we do, because the type of patients that we serve cannot be served in an emergency room, whether it be because they don't trust the individuals there, if they're not easy to trust, or they're in a very bad place with their mental health and otherwise, or because they can't communicate and there aren't supports and mechanisms there to build the kind of support through continuum of care. And they can't advocate the same way that perhaps you and I can if we walk into an emergency room or into a specialist office. So it's interesting to me that the model of service that the province is looking for right now already resides in community health centers and our partner organizations. So when funding becomes available, and they call it, innovation and primary care expansion, give us the money. We're here. We will hit the ground running. Like we already have the interprofessional teams. We're already on the ground. We're already working collaboratively with our community partners in response to whatever the needs are in our various communities. And so if there's a message that I would love to get out there, that's what it is. We're here. We're already doing it. Please give us the money, and we will show you that we can continue to do it. I think that's what we're trying. I hope the awareness that we have this week maybe helps us to get that message across.
Well, so you don't need to reinvent the wheel. You need to just make sure it can roll and
Right.
get going and sustain. And as we end, I could speak to both of you all day. It's amazing how the time flies. So in our last few minutes that we have here, Sarah, I want to know what it is that your message is, to Tara's point, for everyone with this week, because you've got different topics that you're focusing on and you're promoting awareness around, which are really interesting. But there's something that I saw when I was looking into your organization and your ethos, where you talked about the fact that your clients, the vulnerable people populations that you're serving through community health, are the moral owners of what you do. And that's very strong language to describe that kind of relationship. So can you I think my OShow viewers will find that fascinating. What does it mean to have vulnerable populations as your moral owners? And what do you want the people in our final moments here in Ontario to understand about this week?
Yeah, I think being accountable to community and being accountable to the people that face the most barriers. And for us, we have five priority groups, including Black, 2S, LGBTQ+, Francophone, Indigenous, and rural, remote, and northern. And those are the groups of people in Ontario that face the poorest health outcomes. And so those are our priorities. And so being accountable to community, I think, is the way forward for the health system. And without being accountable to community, if we keep being accountable to the decision makers or the provider's needs, or the needs of what works in a schedule or a contract or a funding agreement, we need to actually center the voices of the people that are being left behind and the people whose lives are being negligently affected because we're not focusing on their needs. So that's what it means for us at the Alliance to be accountable to moral owners in that way. And I think that what our message is that community health matters. Community health is proven to work. As you said, we have our population, the folks that our members are serving, are 68% more vulnerable, and yet we divert costs on an annual basis to the emergency department by $27 million each year. And that is because of the type of care that it is a community healthcare model. And so it's important, it influences the system in a positive way financially, but it's also the right thing to do. And it means that people can live their lives in the ways that they want without having to face the barriers that they currently face.
I was able to help with some of the work and that Tara and her team are doing at Community Health Caring in Kitchener-Waterloo. But Sarah, it's our first time meeting, and I was really not aware of what the Alliance does and the messaging that you're putting forward. And I think for so many of us who are frustrated with what we're hearing about in the healthcare system, to know that there are so many organizations that are working together to keep it not only working for people in Ontario, but also that moral ownership by the people who are the most vulnerable, most needing of healthcare and support. That's very powerful, as we're seeing everything that's happening in the world, to know that there is that moral ownership around that issue, and the fact that increasing access for people who face the toughest barriers makes the healthcare system better for everybody. So I know you're taking your message to Queen's Park this week. There's lots of events that are happening. I'm sure people can go to your website to find out about them. But I want to thank you both for helping our audience to understand who needs the support in this province and some of the solutions to provide that very important support. Thank you so much, Tara Groves-Taylor from Community Health Caring in Kitchener-Waterloo, and also Sarah Hobbs, the CEO of the Alliance for Healthier Communities. We all need healthier communities. Find out more about what they're doing this week. And thank you for watching the OShow. If you're enjoying the topics, they're always intense. Please subscribe on YouTube, and we'll keep pumping out the good content for you. Thank you both for all that you do.
Thank you. Thank you for highlighting this.
When you care about current affairs, it's on the OShow. And when you want to get clear what's going on here, it's on the OShow. If you like to stay in the know, tune yourself into the OShow. It's the OShow. Laura Babcock's the OShow. With a lot of great guests, she puts them to the test on the OShow. There's no doubt they'll be calling them out on the OShow. stand for something or fall for it all. Ontario, hear the call of the OShow. It's a podcast, the OShow. Laura Babcock's the OShow. Stay informed with the OShow, OShow.